Hi everyone, my name is Albert. I'll be talking about my case study, give you kind of a summary, and then run you through what intervention I think is best and why. So a summary of my assignment, the patient of this case studies a 6-year-old male who completed a psychological evaluation and was diagnosed with autism spectrum disorder level 1 and attention deficit hyperactivity disorder, hyperactive type. The focal treatment priority of this case is the treatment of his autism spectrum disorder diagnosis. My practice-related question for this case study is what interventions are most effective in the treatment of ASD among children? The type of client that this practice-related question targets are children who have been diagnosed with ASD, autism spectrum disorder. Symptoms of ASD include, but are not limited to, delayed language skills, delayed movement skills, delayed cognitive or learning skills, hyperactivity, impulsivity, and or inattentive behavior, unusual eating and sleeping habits, unusual mood or emotional reactions, repetitive behaviors, and self-harm behaviors. Some of the things that my client has experienced are the typical poor eye contact, issues maintaining it, issues communicating socially, both verbally and non-verbally, some rocking, spinning, repetitive behaviors like those, just a number of things that fall into those different categories. The desired change for this practice-related question is to increase patients' well-being, while increasing adaptive behaviors and decreasing maladaptive behaviors, and to improve the patient's ability to participate in a structured setting. So, strengths and weaknesses of the evidence that I had gathered. Multiple of the studies I found used the weakest method of sampling, convenience sampling. On the contrary, Hayward ETL used cluster sampling to gather their participants, which would result in improved external validity. Regarding measurement, 3 studies used validated measures to record progress and outcomes among participants. Examples of these measures included the Autism Diagnostic Interview Revised, Social Responsiveness Scale, the SRS, the Vineland Adaptive Behavior Scales, and the ADOS, which is the Autism Diagnostic Observation Schedule. One study, on the other hand, did not use validated measures, but instead used Inter-Observer Agreement, or also referred to as IOA. Although IOA ensures that the data collected is both reliable and accurate, a combination of validated measures and IOA would produce more generalizable results. 2 studies designed their experiment well by using a between subjects experimental design with random assignment of participants. On the other hand, 2 studies used a quasi-experimental design, meaning that their groups were not randomly assigned, in turn threatening their study's external validity. Regarding the 6 systematic reviews I found, only 2 of the reviews included a method section describing how they conducted the literature search, which was kind of surprising. So the most appropriate evidence-based intervention that I came to the conclusion of was uh, applied behavior analysis. So after thorough consideration, I decided that ABA, applied behavior analysis, was the most appropriate intervention for my client. I suggest ABA treatment because it has the most substantial amount of research documenting its effectiveness. ABA has proven to be effective in reducing inappropriate behaviors and increasing communication, learning, and appropriate social behavior. Agencies that provide ABA coordinate with parents to outline areas of importance, and then focus on improving those skills within the child. This coordination between clinician and parent will benefit the child, family, and agency if implemented effectively. Additionally, my patient would receive an individualized program designed specifically for his needs using a variety of behavioral strategies or interventions. This would ensure that my client's values, characteristics, and expectations are incorporated in the individualized plan before beginning the intervention. For my client, because he is a minor, the values, characteristics, and expectations would be set by the parent. So to apply this, I would present the intervention information to my client's parents by stating that ABA currently has substantially more scientific support than any other behavioral or educational intervention for children with ASD. Additionally, I would recommend that families should strongly consider implementing ABA, and be cautious about other approaches because many are untested and lack scientific support, unlike ABA. Modifications can easily be made to ABA in the intervention based on the client's values, characteristics, and expectations due to ABA's individualized approach. To effectively apply this intervention, I would need training in ABA and on-site supervision that would ensure interventions being implemented correctly. Preferably, we would refer the patient to a already well-known and effective ABA clinic, like MSU Child Development Laboratories. But in this case, if I were to train it, then I would require training and an on-site supervisor. Regarding the sequence of implementation, I would refer to my ABA trainer or supervisor for the instruction, as they are professional in that area. To produce results, ABA therapy relies on repetition for a child with autism to learn and demonstrate new skills. Therefore, the more deficits a child has, the more sessions they will require. Research has shown that 40 hours of therapy for a child is a crucial number in order to see significant improvement. Studies have also shown um, that 20 to 40 hours of therapy can be optimal for a child needing comprehensive intervention. If there are only a few specific skills or deficits that need to be worked on, 10 to 20 hours may be effective. Um, because the client that I'm evaluating is 6, that window for 40 hours a week might have already passed. Typically, children who do 40 hours a week are between the ages of 2 and 5 because they're not in school yet. But because my patient will likely be, or my client will likely be entering school, they might have to do ABA after hours, which we'll talk about a little bit more, which will probably limit their ability to do 40 hours a week unless they just can't unless their deficits are so severe that they can't get in the classroom, and then they actually do require 40 hours. Um, so implementation directions. Regarding my client, I believe that it would be best if he started at 40 hours of therapy a week and his hours could be reduced based on his needs and progress. This number could be adjusted based on the patient's schedule or the parent's schedule or the child's schedule, expectations and or values, but I would initially suggest that the client participate in 40 hours of therapy a week to increase the likelihood of effective intervention. Plans for each session would be based on the client's needs. Therefore, an initial assessment oriented around identifying my client's deficits should be conducted. This would enable myself and clinicians to center sessions around my client's specific deficits and have a more comprehensive understanding of how many hours of therapy my client would require. The duration of treatment would be dependent on the client's progress and the number of hours the parents were willing to have him participate in ABA. If the client can complete 40 hours of ABA, then the duration of treatment will likely be shorter. But if the client is unable to participate in that many hours of ABA due to school or other obligations or parent obligations, then the duration of ABA will be much longer. The timeline for treatment will be dependent once again on the client's progress and the parent's expectations or goals for the child. To effectively evaluate and process, or to effectively evaluate both the process and outcomes of the intervention, I would use a single system withdrawal reversal design for each deficit the intervention targets. So, for instance, if we're targeting eye contact, that's why I said for each deficit, we're going to have different interventions, different strategies, different behavioral techniques to improve those areas. Firstly, I would initially establish a baseline by using a program such as Response to Name. A positive score would be given when the patient responds with eye contact when their name is called, and a negative score would be given when the client does not respond with eye contact when their name is called. Then I would begin the intervention focused on improving the client's ability to maintain eye contact. The intervention will continuously measure the patient's outcomes and reinforce the adaptive behavior, whether that's food reinforcement, play, whatever we decide, whatever works for the child or the client. Through this measurement, I would be able to establish a second baseline and be able to decide whether further intervention was necessary. So typically, I would imagine that it would be, especially to prevent backsliding. So think about your AB graph that we had um, in chapter 12, I believe it was. So we would have our baseline that we establish. How many times is the client looking at me when I say their name? We do the intervention. We're measuring that as we go. We do another baseline to see if anything's improved. If something has improved, great. If we've extinguished the behavior, even better. If we still think there's room for improvement, we continue the intervention and see where we're at the end of it. To ensure that data is collected in a way that is both accurate and client appropriate, standardized and validated measures of collecting data using ABA therapy will be applied. Additionally, supervision will be frequently conducted to ensure that procedures are being followed correctly. The data collected will then be reviewed by the supervising clinician to ensure accuracy as well as client progress. If no client progress can be seen after multiple sessions, differing behavioral interventions can be implemented if necessary. Colleagues will also participate in weekly meetings to discuss results and the effectiveness of differing interventions. So for evaluation and feedback continued, I would also like parents to meet with clinicians to discuss progress, at-home interventions that parents can implement, and any new behaviors that arise on a monthly basis. This will be a time for clinicians and parents to share results of the intervention. In addition, parent questionnaires such as the Vineland and Social Responsiveness Scale will be administered every 3 months. This will provide clinicians with standardized, validated, and reliable scales that detail what behaviors have improved, not improved, or worsened over the previous 3 months. Uh, Lastly, in terms of anti-racism, power, and privilege, The considerations that should be taken in include a couple things. These are not all of them. These are just the things that I thought of. So clinician-client power imbalances may be problematic if they are not addressed by the supervisor or the attending clinician. Also, access to interventions is probably the largest one. Insurance requirements are often strict for ABA. Many insurances do not pay for ABA, and ABA is often expensive and associated with white privilege due to its cost. Location and availability of services is also a big impact. Based on the family's location, ABA services may be harder to find, especially if they live in a less affluent neighborhood with less available services. Um, Lastly, the family's positionality may also pose a threat to intervention. For instance, some recent social movements have described ABA therapy as forcing individuals with autism to adjust to our societal norms, that being the typical person, um, instead of society accepting them for who they are and the behaviors that they do have. If the family holds views that are similar to this view, their acceptance of treatment is unlikely. So all in all, that is my intervention that I would apply to my client. Um, I look forward to hearing people's feedback. Thanks for watching, and thanks.